Angel Miner and I are delighted to welcome Anna Mendez to This Week in Virginia. Anna is the Executive Director of Partner for Mental Health, a nonprofit advocacy and direct service organization in Charlottesville. In addition, she's the board president of Mental Health America of Virginia and chairs their public policy committee as well. She's a fellow at the University of Virginia Equity Center. Her research focuses on decriminalization of mental illness. She's on the board of the Charlottesville Albemarle Therapeutic Docket, a jail diversion program, frequently seen consulting to state agencies and commissions on Virginia's mental health issues. And Anna resides in Albemarle County with her husband and their 6-year-old daughter. What I didn't say is that Anna's experience is extensive beyond what she's currently doing, in that she has worked at one of our state hospitals in discharge and also worked with the Community Service Board. So with that background and with the opportunity that I had to listen to Anna testifying before Senator Deeds in the meeting just in the middle of July, we're delighted to have you on to tell our viewers what is happening and what is not happening here in the Commonwealth with regards to mental health. If anyone's been following the news much at all, they realize that in the news they've been seeing something about state hospitals not admitting patients. So that's sort of the immediate crisis. So Anna, thank you for being our guest, and let's turn it over to you. And I have questions, and Angel has some after you kind of help lay out the picture for us.
Yes, absolutely. David, Angel, thank you both for the invitation to join you. I'm always eager to talk about Virginia's mental health care service system. So to provide a little bit of context about the current crisis that I think has gotten everyone's attention, David, as you said, earlier this month, the commissioner of the Department of Behavioral Health and Developmental Services closed 5 of our publicly funded state psychiatric hospitals to new admissions. In 2014, as a result of the tragedy experienced by Senator Deeds and his family, Virginia passed what has become to be known as the bed of last resort obligation for our state hospital system. And what this means is that any individual who is found to meet the criteria for involuntary inpatient treatment will be guaranteed a bed in our state hospital system if at the end of an 8-hour period of emergency custody, a bed in a private hospital cannot be found for them. And so this freezing of admissions to our state hospitals means that today, so for the last, I think it's been 2 weeks now, for the last 2 weeks, Virginia has been failing to honor this obligation to its residents.
Well, thank you very much for painting that picture, and it's certainly a picture that causes concern. Now, this may be a loaded question, and you have your own perspective. Now, others may see it differently, but you're always willing to speak the truth as you see it. What caused the crisis? Because I think there's been some decline in the number of patients in the state mental hospitals. What led to the decision, you think, that to close it?
That's a great question. So as kind of distressing and as unprecedented as Commissioner Land's decision is, For many of us who have been following what's been happening in our state hospital system, it was also not surprising. I really think that, to be honest with you, I think my surprise was only that she did not make the decision sooner. And the reason I say that is because state hospitals, I think like many other employers in this new COVID world, are having a workforce shortage crisis. So our state hospitals have had a patient census of around 100% for the last few years. So that is not new. The number of patients in our state hospital system has been at very high levels for a very long time, and that has not changed. But what has changed, the lack of ability to maintain staff in these facilities. So some of these facilities were really functioning at close to 50% staff. And you cannot keep your residents safe and you cannot keep your staff safe when your resident census is 100% and your staff census is 50%. And you certainly cannot meet your obligation to provide care under those conditions as well. So why we've gotten to this point of having to freeze admissions to 5 of our 8 hospitals is really, at least in part, because they're understaffed. And the reason that they are understaffed is because Virginia is paying its direct service employees in the lowest stanine, so the lowest 10% of positions of kind of equal stress, equal credentialing, equal responsibility. Staff that work in Virginia state hospitals the state was just able to get like a compensation study report, and they knew they were low, but they didn't realize they were that low. So insufficient staff compensation is a huge part as to why we've ended up in this current crisis of having to close our state hospitals to new civil commitments. So there's really 3 reasons. A second reason that we are facing this crisis right now is because Virginia has historically significantly underfunded its community-based services in favor of supporting hospital beds. So there are only 2 other states in the nation that have more hospital beds on a per capita basis than Virginia does. Yet, Virginia ranks 30th in per capita mental health care spending. So we've got all of these beds and we spend really low. So where do you think the bulk of that spending is going? It's going to hospital beds. And you can build all the hospital beds you want, but having all the hospital beds in the world does not help keep people living meaningful, healthy, and well lives in their community. So we're not paying staff enough to keep them wanting to work in the hospitals. We're not investing enough in community-based services that have been shown to prevent the need for hospitalization in the first place. And the third reason that we're having this crisis in our state hospitals is that the number of patients being held under temporary detention orders, so we're specifically talking about involuntary patients right now, the number of patients being held under temporary detention orders that are able to find a bed in a private hospital has been decreasing. And so what this means is that Virginia's publicly funded state hospitals are increasingly being called upon to provide short-term and acute care, which is something that they were never designed to provide in the first place. And we have seen this trend really develop since the bed of last resort obligation that I mentioned earlier in our conversation.
Anna, is the funding that the Commonwealth provides, when it's so low, I think some of your figures we saw in an op-ed, we rank about 30th in overall spending and about 39th, ranked even lower in community health. Has it been that way for decades? I go back, way back to Blue Ridge Community College when a mental health technician program was being developed, and I was assisting in developing that. And Western State Hospital was being, patients were just being moved out. And I have not stayed on top of this over the decades, but is our lack of funding anything new, or is that just historic?
It is absolutely historic. I'm sure you and probably many of your viewers are aware of the letter that former Commissioner Barber wrote, where he really just made it incredibly clear that this was a problem that's been a long time in the making. We have underfunded. Historically, Virginia has underfunded community-based services for so long that this sounds a little trite, but like we're paying the piper for our bad mental health care policy decisions. Like we're reaping what we sow now by not having enough funding in community-based services to be able to help people remain in their communities.
How much would it take to get us moving moving forward? I'm sure that you and some of your colleagues and others have looked at this. The Deeds Commission and others are looking at it. What's your perspective? How many is it? Is it $1 billion? Is it $2 billion? Is it less than that? What's needed?
Virginia has the privilege of being able to say that we are now the 10th wealthiest state in the union. But yet we persist on only being 30th in per capita public mental health care spending. And at Partner for Mental Health, we believe that the 10th wealthiest state in the nation should have the 10th best funded public mental health service in the nation. And in order to do that, in order to come from 30th to 10th, we would actually have to double. We would have to double our current investment in mental health services. And we think that the residents of Virginia who live with mental illness and the people who care about them deserve that. They deserve a system that is funded on par with states of comparable wealth. So we're very hopeful that the outcome of some of the federal dollars, some of the federal COVID relief dollars are going to be infused into the mental health care system. And it's also important to remember that those are one-time funds and that this is not a solution that has a one-time problem. So we're going to continue to have either this conversation or variations on this conversation into perpetuity until we do something differently. And doing something differently looks like doubling our current investment.
And would most of that, if not all of that, being in community-based services? I guess the other side of my question, is there a need for more beds? Are there enough beds in the state and the private hospitals to accommodate those that need to be hospitalized? Or so if we're looking at doubling and maybe moving toward that, where does the money need to go?
The bulk of it needs to be invested in our community-based services. The majority of clients that we have the privilege of working with at Partner for Mental Health, not all of them, but the majority of our clients who experience a crisis, and we're defining crisis by either being a hospitalization or a period of incarceration, the majority of them understood that they were not doing well prior to the crisis event, and they attempted to access community-based care prior to the event that led to either their hospitalization or their incarceration. Not all of them. I'm certainly not saying that there is never going to be a need for hospitalization or involuntary hospitalization for that matter. But we absolutely need to create a system where people can access care when they realize that they need it. As to whether or not our system currently has enough beds, we have more beds per capita than almost every other state in the nation. I think the one place where I would kind of defer assessment to someone else would be in our child and adolescent system. At Partner for Mental Health, we work exclusively with adults. So I'm not interested in kind of putting my oar in a system that I'm not as familiar with. And I do know that right now we only have 18 child and adolescent beds in our state system. So I believe that that is potentially a different conversation than what is happening in our adult system.
Okay, I've been just rolling on asking the questions, and you've given us a great deal of information. And Angel, I know that you have some questions that you wanted to ask. Let me defer to you.
Yeah, so I was listening to you. You were saying how we're the 10th wealthiest state, but we don't have enough beds. Why is that though? Like, why?
Well, I think for at least for adults, we have more beds than almost any other state in the nation. So why are we if your question is why is the 10th wealthiest state only the 30th in per capita funding, I think there are a lot of reasons for that, and I do absolutely believe that one of them is because typically people who experience serious mental illness are not a particularly strong constituency, right? They're not people who are mobilizing to vote. They are people whose voices are generally pretty easy to overlook. And so one of the things that we're trying to do at Partner for Mental Health is to change that, because we know that every single family in the Commonwealth is touched by the experience of mental illness in some way, shape, or form.
Angel, do you have another question?
Well, I don't know if you know as much about adolescents as you do with adults, but what are some resources that younger people who are still dealing with the effects of COVID and their mental health, how can they find resources and help as well?
Oh, that's a really good question. You're right. I'm absolutely not an expert in like child or adolescent issues, but what I can say is that there's a really great resource called the Virginia Copes Line, and it's actually open to anyone in Virginia, like youth through like youth through 100 or 110, that where people can call specifically to get emotional support as well as resource referrals related to stressors or emotional distress that they are feeling as it relates specifically to the pandemic. So perhaps like anxiety that's arising from, do I need to wear a mask in public or not? Why am I hearing all this conflicting information? to I've lost my job because of COVID and I haven't been able to find employment, or do I send my kid back to school if they don't have to wear masks, or just all of that. The Virginia COPES line, which is run by Mental Health America of Virginia and funded through the Department of DBHDS, is a really, really great resource for people.
For our viewers who maybe don't understand some of the process and understand what the concern is, they hear people being held in jails, and the sheriffs have been outspoken about the problems that they have. Explain a bit about this temporary detention order, the TDOs as they're called, and how that works, and explain the problem that's caused. Not asking you to be the advocate for the sheriffs, but the advocate for the patient in that process.
Yes. So what happens if someone in Virginia, if someone is observed, if someone has concerns about someone, maybe they're concerned that they're going to hurt themselves or hurt someone else, or that they can't meet their basic human needs as a result of having a mental illness, then they can ask a magistrate to issue an 8-hour emergency custody order, which allows a law enforcement officer, so generally a police officer or sheriff's deputy, to pick that person up and deprive them of their liberty, right? So it's almost a form of arrest, but not quite, because there's not been any criminal charge. So pick them up and take them to a hospital where a clinical team has 8 hours in which to assess them to determine whether or not they meet criteria for a 72-hour period of temporary detention. And during this 8-hour window, while the clinical team is doing what's called their pre-screening assessment, the person in crisis remains in the custody of the law enforcement officer. So what this means is the law enforcement officer who executed the ECO needs to remain with the person in crisis in the hospital. And for some of our jurisdictions, some of our more rural jurisdictions, they experience this as a real burden. They might only have 2 deputies working at any given time, and now 1 deputy has to spend 8 hours in a hospital. So not to mention, of course, what's more important is the impact on the person, right? Because here's this person, remember, there is no criminal charge here, right? This is a person who's experiencing a mental health crisis, and they're being often handcuffed to the side of a gurney in an emergency department, and a police officer is standing next to them. I mean, that's certainly not how I would want to be treated in a mental health crisis, or how I would want my family member to be treated in a mental health crisis. So we have heard the Sheriff's Association speak loudly for the need to solve this problem, and we certainly empathize with them, and we understand that, you know, as much as their deputies don't want to be in the hospital, the people in crisis don't want to be in the custody of a police officer for 8 hours either. However, we don't believe that one of their solutions, which is the call for more beds, is actually going to have the effect that they want. I mean, what we've seen right now in Virginia is we have closed beds in our state hospitals because we can't staff them. So building more beds when we're closing ones that we already have is clearly not the solution. And that's why we're calling for greater investment in community-based services.
From what you know from your colleagues around the country, how is this handled better in other states? I heard the commissioner, and you did too, saying that there needs to be someone else who stays with the patient. It needs to be, and there was some discussion about what that staff position would be called. But is that what happens in other states? Or are we, again, unique or near the bottom as far as how we're handling the TDOs?
Each state has their very own unique system for implementing involuntary inpatient care. Having said that, Virginia is an outlier. And we are an outlier because right now we are the only state that is depending upon our publicly funded state hospital system to provide short-term acute care. So just want to be incredibly clear about that. Reasonable people can have differences of opinions as to why we are in the crisis that we're in. However, it is also true that every other state in the nation has found a way for private hospitals to provide short-term acute care, and they do not use their publicly funded state hospitals to do so.
I almost paused because I think that's the second time I've heard you say that. The first was before the commission, their meeting. And it does appear that it would be something that legislators would be seeking to address and to determine what steps need to be taken. Special session begins in August on the 2nd. Will last, who knows, it will last a week or two. And some one-time spending will occur. We look forward to learning more from you and from your colleagues, and also hearing from those who deal with children and adolescents about what are the issues that need to be addressed next January, when on the 12th of the month, the General Assembly convenes for its regular session. But Anna, we thank you so much for laying this out today for our viewers. And before I would close, if there was something else that you wanted to say and you thought, David has not asked me another question, then let me give you the final word before we end for the day.
Oh, thank you, David. Thank you so much. Thank you so much for this opportunity again. I would just really call upon all of our elected officials to really reflect for a moment about what type of system would they want their child or their spouse to experience if they were living with a serious mental illness. Like, would they want the current system that we have, which doesn't fund much, and the majority of what it does fund is inpatient hospitalization? No, probably, that's probably not the system that they would want. So the system that we currently have is not the system that we would build if we had no system and had to build one today. So let's learn from the wisdom of all of the other states who have currently figured out better ways to utilize their state facilities and are doing a better job of supporting their residents that are living with mental illness, because I know if other states can figure it out, that Virginia can as well.
Thank you very much, Anna Mendez. That's the challenge before our elected officials. Thank you.
Thank you.